So the biggest obstacle is is trying to figure out who is inherently resistant to the therapy, right? So we really need biomarkers to determine whether or not the patient is going to respond to therapy. Those are called predictive markers those are predictive markers as opposed to prognostic markers, where prognostic markers gives us indications about risk for relapse after surgery, right? And so those are prognostic markers, and those are important too, because if the risk for recurrence is very low after surgery, then those patients can probably be spared any systemic therapy that would have side effects and actually costs. But if the prediction that there's a high risk for relapse, those are the patients that we should target for these treatments. So those prognostic markers are important too. The predictive markers are important because you don't want to subject patients to therapies that they can't respond to, right? Because they have side effects and they have costs. So right now, the focus is there's probably several focuses going on in parallel. One is to try to improve the complete pathologic response rate, and the other is trying to identify predictive markers that would tell you that this patient either is or not likely to respond to a specific therapy, whether it's single agent immunotherapy or combination immunotherapy or both that they may not respond to. And that's probably the main obstacle right now, moving forward, is trying to identify patients who are resistant to the immunotherapy and trying to identify ways to overcome that. So, for example, one way to try to overcome that would be to inject something into the tumor. It's called oncolytic immunotherapy, and right now there's a couple. There's actually a herpes simplex virus that's been genetically modified that could actually change the tumor microenvironment to allow patients to respond to immunotherapy. And one of the ways to determine if a tumor is going to respond to immunotherapy is to look into what's called the tumor microenvironment to see if there's any T cells there already and what type of T cells are actually there. Some of these oncolytic therapies that you can inject into the tumor could actually increase the infiltration of T cells and allow patients to actually respond to immunotherapy. So that would be one strategy. The combination therapy would include something that would allow infiltration of T cells that weren't there to begin with. And then patients might be able to respond to the immunotherapy. So those are some of the strategies that are moving forward in parallel with trying to find agents in combination with immunotherapy that can increase the complete pathologic response rate. So I would say that those are really the two main obstacles, is identifying predictive markers for response and resistance and therapies that can increase the complete pathologic response rate.